Hello everyone, Max here again. This is lecture number 2 on EKGs, and we're going to talk about why this stuff all matters. I added some facial features to my dude here, and I'm sorry about it. Taking a look at what we've accomplished in lecture 1, let's start creating a map on our 12 lead. As you can see, lead 1 and AVL are looking at the myocardium from a left and lateral position, so let's mark these on our 12 lead. Next, we can see that lead 2, 3, and AVF are all looking downwards toward the feet or the floor. An important reminder is that we are looking at the inferior aspect of the heart, which anatomically is the right ventricle in the right side of the heart. As we learned, the heart sits sideways in the mediastinum. And look at those little feet to remind us again. So let's mark 2, 3, and AVF with an orange highlighter. Next up, we are going to take a look at our precordial leads. Remember, these guys sweep the chest starting anteriorly and moving laterally. So we are going to create a division at V4 to separate anterior from lateral. This gives us V1 through V4 as anterior. And let's highlight these purple on our 12 lead. To finish with V5 and V6, they are placed laterally on the side, and we are going to include them with 1 in AVL with the blue highlighter. Notice how AVR is left out for now. I will come back to him in my final lecture of the series. To complete this mapping, we can now see that we have a lateral, inferior, and an anterior lead designated by our blue, orange, and purple highlighting. A small side note on V1 and V2. They are anterior leads. However, because of where they are placed on the chest, they can be specific to the myocardial septum. As you have or will learn, systole is the portion of the cardiac cycle responsible for ejection of blood by an actively depolarized and contracted myocardium, either through the aortic valve or pulmonic valve. Diastole, on the other hand, is the relaxation phase, where filling predominates, moving blood past the mitral and tricuspid valves. Filling also occurs in the coronary arteries during this time period. The coronary arteries are what we're going to talk about next. So now I have this absolutely beautifully drawn and very anatomically correct heart. So let's orient ourselves with some of the structures. The large tube coming out of the top and over the heart is the aorta. The aortic valve is trileaflet, meaning there are 3 leaflets associated with it. 2 of them are coronary leaflets because they are associated with a coronary artery, either right or left. On the right, we have our right coronary artery that tracks downward and covers the right ventricle. In the majority of the population, the right coronary artery gives rise to the posterior descending artery. This is important because our 12-lead EKG does not directly look at the posterior aspect of the myocardium. However, it can indirectly look at it. On the left side, we have the left main coronary artery. This branches into the left circumflex artery laterally and the left anterior descending artery anteriorly, and covering the interventricular septum. So how can we correlate these arteries with the 12-lead EKG that has been so beautifully taught to us so far? So we've said that lead 1, AVL, V5, and V6 are our lateral leads. So looking back at our drawing, we can evaluate this further. As we can see, this high and lateral portion of the myocardium is covered by the left circumflex artery. So, our lateral leads correlate with the left circumflex artery. And then we said lead 2, 3, and AVF are our inferior leads. And remember that the inferior aspect of the heart correlates with the right side and the right myocardium, not exactly the apex itself. So our inferior lead is associated with the right coronary artery. While I'm wasting your day away scribbling random things on the screen, I thought I'd take the time to talk more about the right coronary artery. The right coronary artery has two small branches in the atrium that are very important in giving two crucial pieces of tissue nutrients. These two areas are the SA node and the AV node. These nodes, which I will discuss in detail in Lecture 3, are the pacemakers of the heart. Ischemic damage to them can cause arrhythmias, like a heart block, which, oh by the way, I will talk a lot about in Lecture 4. Lastly, we have our anterior leads. I also drew in the septum on the heart on the diagram to relay the point that the LAD covers the interventricular septum as well. Its other name is also the interventricular artery. So, our anterior leads are associated with the left anterior descending artery. So far we've covered the LAD now, the right coronary artery, the left circumflex. I'll discuss the left main later, but what about our posterior descending artery? As I alluded to earlier, the PDA in most people arises from the right coronary artery and feeds the posterior myocardium, and our simple 12-lead EKG just can't get a look at this directly. In order to talk about this more, we need to switch gears for a minute. We've talked about what our EKGs are, why it matters, but we haven't actually talked about what we're looking for in these EKGs. So let's do that now to continue this conversation. The most critical thing to evaluate in regards to an ischemic event in the heart is something called ST elevation. Now I'll get into the specifics of the cardiac cycle in the next lecture, but for now, I want you to understand that there are general signs of damage to the myocardium. Sometimes these signs can show elevation of the ST segment, other times it can show depression, or inversion of the T wave. The ST elevation is a sign that the heart is damaged and is changing its physiologic and metabolic environment that can be seen and measured. On the screen, I am showing you drawn examples of ST elevation, ST depression, and now T wave inversion. These are all based on 2 points. One is at the isoelectric line on the left, and the other is at the J point on the right. The parts of the EKG include the P wave, the QRS complex, and the T wave. I will have a whole video describing these though. For a basic understanding, sometimes it can help to think of the ST elevation as the primary problem and the ST depression as the secondary problem. What I mean by that is that when there is damage to the heart wall, you can both directly and indirectly see the changes on the EKG. This is something known as reciprocal changes. Reciprocal changes are the ST depression you see opposite to the damaged area of ST elevation. So how can you immediately tell which lead is opposite to its corresponding lead? This can be difficult to try and map out, especially in real time or in a potentially stressful situation. The quick memory aid that I have used for a long time and will probably continue to use is something called PALS. With PALS, you write, or think, of the word PALS written out in a circle. This way the letters can line up with each other. PALS stands for each area of the EKG: posterior, anterior, inferior, lateral, and those septal leads, V1 and V2, that we talked about earlier. For example, let's say we see EKG changes, like ST elevation in lead 2, 3, and AVF. We've learned that this is correlated with the right coronary artery, and we would call that an inferior ST elevation myocardial infarction, or a STEMI. Well, where would you go to look for reciprocal changes, you might ask? Let's check back in with PALS. All you have to do is circle your area of ST elevation, in this case it is inferior, and connect the dots with the anterior point and the lateral point. As you can see right now, I'm circling the eye for the inferior leads where we saw ST elevation. Then I can connect the dots to the anterior and the lateral leads, which is where I would expect the ST depression or the reciprocal changes to be. So, any of these areas, anterior or laterally, can express ST depression. However, interestingly, with inferior MIs, ST depression in AVL has been shown to be highly specific as a first sign of an RCA occlusion, and therefore an MI. So I know this was a lot of information, and I hope my silly drawings helped at least a few people out there understand why EKGs can be important. In the next lecture, I'm going to talk about rate, rhythm, and axis. You guys are one step closer to being experts. Thank you for listening.